Well, thank you very much to the Aspire Group for inviting me to give you this presentation about remote monitoring of IVF. It's not something that I do. It's something I'll touch on a bit later on how I'm involved with developing, and it's something that really our patients would aspire that we do. Surely it's best for all concerned. So thank you for asking me to give this talk, and thank you for listening. So these are my disclosures. I have received educational support, and obviously my presentation does have obviously this conflict of interest. I am involved in the IVF industry. I've got shareholdings in that, and I've received honoraria as listed. So we have become so reliant on face-to-face medicine over generations. That is how we did medicine, and that's, I believe, how the majority of us enjoyed working. But COVID has taught us many lessons, and you know as well, perhaps more than I do, how it's impacted our lives and the lives of our patients and the way we deliver our medical care. This is an article from the ABC. It says, how a pandemic changed IVF for these couples. Obviously, this is a same-sex couple. And it says, before Kat began IVF, she expected her wife, Kirsten, to be there by her side. But COVID meant that was no longer possible. It's been really isolating, especially if being a same-sex couple, you already have that fear that the other mother won't have a connection to the pregnancy of the baby, said 33-year-old Kat from Brisbane. Kirsten felt very lone, left out and sad. So therefore, the pandemic has really impacted individuals and couples' fertility journeys in lots of different ways, including delays and having to go it alone. And we've all seen that about how the restriction on access to hospital, partners being present, and even shutting down of IVF delivery, but mainly how its patients have become fearful of coming to hospital. The partners cannot be there to support them, and that's made us think about how we deliver medical care. There's another story. At the start, I called my partner during the appointments so he could listen in, but that didn't really work. As the cycle progressed, I was fully involved and excited, but he became more withdrawn because he didn't really feel part of the process. Melanie says the hardest time was egg collection, which was day surgery. My partner wasn't allowed even in the hospital with me. He had to drop me off at the door. Checking into hospital COVID-19 checks and pre-surgery preparation took a long time, and it really left me alone with my thoughts. By the time I was on the operating table, I was crying because I was scared and apprehensive. Psychologist and Monash IVF Counselling Service Manager Rita Alisi said the separation can increase stress for both parties. Not having their partner present with them is highly distressing, but it can also be really isolating for the partner too. The partner, their role in taking on support, so when they've been denied that access, they feel disconnected from the treatment process. So, as if we didn't really know it, but this has demonstrated the impact that isolation and the way we've embarked on IVF with the institutionalization of care really has impacted on fertility treatment and the journey that our patients go through. Surely one thing we've learned is there's some benefits of the virtual consultations. So here's another quote. Those external pressures they experience, usually being in the workplace and having to take time off to duck out for appointments, they all could do all of that. But obviously nowadays with virtual consultations, that's one positive that we've learned. So really, what have we learned from the pandemic? As if we didn't know before, IVF is very stressful. And now perhaps even more so. Coming to hospital is stressful and even potentially fraught with risk of catching infection. So patients do not want to come to hospital, and even hospitals do not want patients coming, which is perhaps a completely different way of viewing medicine. as we're well aware, it's really important to have a supportive partner around when undergoing treatment, and therefore, with the exclusion of the partner, that creates all sorts of challenges and stress and distress for the patient. Plus, as clinicians, we've really learned that telehealth is okay, whereas before we were really resistant to it and thought of excuses why we couldn't do it. It's actually fine, and actually is often better than face-to-face. Patients and doctors can be more punctual. You can talk to two separate individuals in different places. They don't have to be in your rooms. They don't have to be in their same room. They can be in separate rooms. So we're all going through the journey of transformation of medical care in all aspects of medical care, which is really moving towards patient-centered care. That's how we should deliver our service. And we want to really minimize the impact of the stress and impact of the treatment on our patients' experience and their journey. And how have we done that in IVF? Well, certainly we've over years we've got less hospital visits. Patients are now, for many years have been self-administering their medication with very easy, administered medication. There's less monitoring, and there's minimal stimulation IVF. There's even in vitro maturation with hardly any stimulation at all, if at all. There's less injections being used in standard IVF. There's been development of long-acting administration of IVF, of FSH injections. We're getting low OHSS, and there are many ways we can minimize that, which we won't go into, which you're all aware of. But certainly the ability to use an agonist downregulation with an agonist trigger really makes the whole IVF treatment much safer for the patient, particularly with the opportunity now of vitrification and freezing all embryos. So really, we're minimizing the impact on the patient and extending that further with, rather than offering just standard care to all patients, the same treatment, we're offering individualized care. We're tailoring the treatment to what the patient actually needs. So we are evolving with time. Effectively, we're striving to reduce the impact of the IVF treatment on our patients. Because you know your patients as well as I know mine, is one of the major reasons patients cease their treatment is not the cost, and that's been shown by publications in many different jurisdictions where there's different financial impost on the patient. The majority of patients cease treatment due to the stress and distress that it causes, not the cost. Really looking at before COVID happened, that actually remote IVF treatment is not a new thing. Many of you may practice in remote areas, and certainly in Australia and Canada, we do, and Western Australia particularly is a very remote setting. So every day we are thinking about how we are delivering a service to our patients who live thousands of kilometers away. So this is a report from the United States, which is looking at how they were delivering IVF before the pandemic. And this is a retrospective cohort study done on infertility patients before COVID. And they looked at the patient satisfaction and outcomes in infertility patients in the US in a very remote environment. And they had telehealth patients had the diagnostic studies and ovarian stimulation monitoring done by a local gynecologist and only presented to the IVF center for the egg collection and the embryo transfer. And what they found when they audited their data is that live birth rates were equivalent amongst the telehealth and clinic patients, exactly the same. And understandably, the satisfaction rates of the patients were high, and when half of them reporting extreme satisfaction, about 1 in 5 moderately satisfied. So remote monitoring was there. And indeed, we've continued this, and many of you will have done the same. We have continued on some of the benefits with remote treatment, with offering the opportunity for patients to do that in the convenience of their home and at work, and often, as I said, in different sites. And this is a recent review by Berg and Rosenwax in Fertility and Sterility, and it says the coronavirus has resulted in a paradigm shift in the delivery of healthcare, with lockdowns, quarantine, local mandates, and forced many physician practice in the US to move to remote patient visits and adoption of telemedicine. And they go on. They've now adopted this approach. They do pre-screening of referrals, perhaps a nurse phone consult with the patient before their attendance, and then they'll do a telehealth virtual consultation with history taking, arranging investigations, and it goes on, and some of it is actually quite surprising. So I'm not going to go into a great deal about it, but you might want to just look at it. So without laboratory diagnostics available, a complete video examination can provide important information in the evaluation of the infertile male. Conceptualizing the physical examination in general, particularly the male fertility exam, a great deal of information can be gained from virtual inspection. I've just curtailed it there, but it does go on. But it says, asking men to place their cell phone, laptop or tablet on a waist-high table and step back so we can assess their entire body. The patient is then asked to lift up his shirt so we can inspect the breasts for any swelling. The abdomen is then visually inspected for hair pattern, surgical scars, abdominal obesity, abnormal masses. We then perform a genital examination. How, you may ask? Well, the patient is asked to lower his pants and underwear to mid-thigh level, and it's become our practice to reinforce the confidential nature of telemedicine at this point, as well as to ask the patient that they perform this part of the examination in a private location. We then inspect and it goes on, it's another paragraph, so I refer you to the article. But basically they feel that they're able to give a very, very comprehensive medical male examination by telemedicine. Female examination is more problematic, but we're aware that with very good ultrasound examination, a very good pelvic examination can be determined looking for all aspects of gynecological health, antral follicle count, the uterus, fallopian tubes, even by instilling fluid and checking tubal patency at the time. So a very good ultrasound, which potentially can again be done by the local gynecologist or ultrasound department, will provide very good remote information, and also potential looking at presence of corpus luteum and follicle development. But the challenge is, how do we actually monitor treatment? And then some of you may say, well, actually, do we need to monitor treatment? And that's a very good question. Well, many of you are aware that Cochrane Review and the ESHRE guidelines are really not clear on the benefit of actually monitoring a woman during her IVF cycle, which does appear surprising. But obviously they look for high level of evidence, and that isn't really there. Obviously, one would expect it to potentially give opportunity to reduce the risk of ovarian hyperstimulation syndrome, the time of triggering, but the evidence around it is not strong. But I won't go into that's not the right place to be going into the ways and whys of that, because effectively, and I was part of this study, this was presented at ESHRE last year, but evidence is the contrary, is the fact that the vast majority of it actually do monitor our patients. So the question was sent out to several hundred fertility doctors, what is the practice of routine hormone monitoring during ovarian stimulation? And in fact, the majority of specialists, more than 80%, use regular hormone monitoring with ultrasound for monitoring ovarian stimulation to prevent the risk of OHSS being the main reason, but also timing egg collection. So the majority of us do monitor our patients with hormones and ultrasound. So that's what we're focused on. So how can we monitor by hormone monitoring? Well, there's the Antarctica study being done in Europe, and we're still waiting for the final results on this. But this is looking at the benefit of home monitoring of LH surges, and many of you may do that, but really it's not been subject to a formal randomized study. So this was looking at home or hospital-based monitoring of timing for a frozen embryo transfer in a natural cycle, the Antarctica study. we're still waiting for the conclusion of the live birth rates, but in terms of patient satisfaction, we do have that data, and this is published. And it says this study suggests there is no effect on the frozen embryo transfer monitoring strategy on the quality of life, and it indicates that it may be more positive in favor of a patient's home monitoring. And the outcome of the patient-reported experience is only based on non-validated items, which were part of the a Dutch organisation that's quoted there. But before a final recommendation regarding home-based or hospital-based monitoring can be made, we need to make the completion of the Antarctica randomised 2 study to look at pregnancy rates. But certainly it appears that patients seem to they do prefer, as you'd expect, home monitoring. So where's my involvement? Well, we're doing a pilot study of home monitoring of the urine metabolites of estradiol and pregnenolone in women embarking on ovarian stimulation. So, but basically what happens is the woman gets up in the morning, first thing, and many women have been used to doing the first morning specimen of urine, and they pee on a stick. They insert this into what's very similar to a home monitoring, a smart home system. It's a little box that they can keep, which they just insert this machine in. That's actually measuring by ELISA their urine metabolite hormones. And as you can imagine, this is perhaps potentially a more representative measure of the hormones, because it's measuring since the woman emptied her bladder last, so it's probably a good 6 to 8 hours worth of average hormone excretion. This is passed into a machine, and this machine, which syncs with the app on their phone, and whenever the woman has got broadband or Wi-Fi, so she is in the middle of nowhere, and whenever she comes into town or a village or back to work where there is some Wi-Fi or broadband, that will then be uploaded to the cloud, and it'll come down to our computer in the office, where we can measure the hormone levels. So this is basically an opportunity to monitor the urine metabolites of the sex steroids during an IVF cycle. Obviously, we're doing it in conjunction with serum measurements until we validate that this is appropriate. So watch this space. Well, you say that's all well and good. That's the urine you may, but what about ultrasound? That certainly sounds problematic. Well, but apparently not. This has been going on for quite a while, particularly Jan Gerris's group in Europe, where they have a self-operated endovaginal telemonitoring system. Basically, the patient practices until she feels comfortable monitoring her, finding her ovaries and being able to lock in on them. And then she does a pass through the ovary when she's having her monitoring of about 30 seconds. And this is then taken as a video clip, which is uploaded to the cloud for Dr. Gerris's group to analyze. And so this has been going for quite a while. And they did a non-inferiority study. They had about 60 patients in both arms. Patient characteristics were comparable. And they found there was similar ongoing pregnancy rates, 25% in the self-monitoring and 26% in the non-self-monitored group, standard care. They found they had similar numbers of dominant follicles at egg collection, similar number of eggs collected, metaphase 2 oocytes, embryos available for transfer, top quality embryos, and embryos frozen obtained in the groups. They basically demonstrated there was non-inferiority to this approach. And there's the probe there, and there's their monitoring device to help the woman localize on her ovaries, and then it's uplifted to the cloud, and Dr. Gerris's group will analyze it later in the day. As you'd imagine, when they looked at patient-reported outcomes, significantly higher contentedness of the patient and the partner was reported, a greater empowerment that the patient felt, and as well as a trend to less stress. Economic and valuation demonstrated benefits with less loss of productivity for the work, lower transportation costs, and obviously ultrasound and consultation costs. Unfortunately, their study ran out of money, so they had to stop prior to getting the full sample size. But they did demonstrate their numbers they had non-inferiority. And how did this correlate? So this is a further group study. So how this is then looking at how good the patients were actually monitoring their follicles in comparison to a clinician. So they compared the ultrasound reports that were gained from the scans and the follicle measurements to the doctor doing the scans just before egg collection and after trigger. And they found there was very good correlation between the patient and the physician. So very reassuring. And more work's being done by George Griesinger's group in Germany, and they again used a similar system, and they again found good correlation between patient and physician reports. But they did report that 26.7% of instances images were unsuitable for analysis. And the majority of these cases, these were women who were overweight, BMI greater than 25. So it may have a limitation there. So where are we now? Well, this is what the imaging you can get. This is work where artificial intelligence is constructing the follicles, and there's beautiful color pictures there that have been generated by the patient locking in on their follicles. So perhaps the future is where your patient plugs the probe into a connection into their smartphone and uploaded to the doctor. So in future, there is an inexorable progression towards more patient-centered care, which is a good thing. All aspects of future care of the management we should really be trying to view through a prism of providing optimal outcomes for the patient while minimizing the impact on our patients. And certainly the future will include remote urinary monitoring of steroid hormones rather than having to attend various places for blood venipuncture. And potentially that may be in conjunction with self-administered vaginal ultrasound. So with that, I will leave you there and happy to take some questions.